If you don't know me, my name is LeNeika Roehrich. I'm a pharmacist with North Dakota Medicaid. My title is clinical pharmacist, which means I have a few different hats in that role. I deal a lot with provider relations and clinical services. So when there's questions about drug coverage, criteria that require a pharmacist to get involved, those a lot of times get routed my way. In that role, I've been able to partner with the CAP Center to provide a few presentations, put on some enrollment workshops for pharmacists across the state. And that's really what brought me here to talk to you today about billing North Dakota Medicaid for pharmacy services. Lisa, you can go to the next slide. I don't have any relevant financial relationships to disclose to you today. And as far as the objectives today, I'm not going to read each of these to you, but as we go through our slides today, I do want you to be thinking about in the back of your mind, because we will have another breakout session for small roundtable discussion. What types of services do you want to provide that maybe you aren't currently providing? Why is that? What types of challenges and successes have you had in your own practices? You guys are going to be the best resources for each other. I know some of the common stuff that comes up, but you guys really know the pain points that happen when you're trying to bill for services. I'm going to go over some of the common billing challenges that I've seen, but I want to make sure that you guys have an opportunity to learn from each other and also have an opportunity to give constructive feedback for processes that maybe are a little bit difficult. So Lisa will certainly share out my contact information to anyone who wants it, and you can certainly email me if there are things that you want to provide some feedback on in terms of our processes. Open to compliments too. If you have those, I won't, I won't be mad if you send some our way. But no, in any event, some things we can change in our processes, and the ones that we can't, we can always work to educate on, which is part of the reason that I'm here today to speak with you. I'm by no means a medical billing expert in all things, but I am pretty familiar with the services that are being billed by pharmacists, and I can certainly get us to the right people to help bill for services for things that are covered by North Dakota Medicaid. So we're going to do a general overview of the Medicaid billing process, and then we're going to spend a little bit of our time talking about the current landscape, where I'm going to talk about pharmacists currently enrolled, the main services that are being billed, and then some of the prescribing that's happening by pharmacists. We can go to the next slide, Lisa. So as I mentioned earlier, we're going to do a general overview of the steps to billing for pharmacy services. Those are all listed here for you. I'm not going to go through each of the items on this slide because we're going to talk about them individually a bit more in the upcoming slides. But I do want to point out a couple of items that I want you to pay attention to as we go. For Medicaid member eligibility, it's really important to note whether or not the member has traditional versus expansion Medicaid, because services that you're doing in the pharmacy are going to be billed under a medical claim rather than a traditional prescription claim. Covered services is the other area that I wanted to highlight here, because while a code for a service may be covered, there may be other stipulations that have to be met. So even if the code is covered, the service has to be medically necessary, has to be within the scope of practice of the provider. And if a code's description limits it to a certain type of provider, we have to follow those limitations. So things to think about, even if it is a covered service. So just wanted to point that out. With that, we can go to the next slide, Lisa, and we're going to get started with provider enrollment. So I know I said we're starting with provider enrollment, but full stop, you have to be enrolled with North Dakota Medicaid in order to be paid by North Dakota Medicaid for pharmacy services. What I have outlined on this slide is just the process for North Dakota Medicaid enrollment. If a member is on expansion, you would have to, in addition to what's listed on this slide, complete enrollment with our MCO, which we're currently contracted with Blue Cross Blue Shield of North Dakota. So for provider enrollment, it breaks out into a couple of different pieces. We have an online application and then a supporting documents portion, which I like to call the paper application. It just helps me delineate the two pieces of the process a little bit more. Before you get started on enrolling for North Dakota Medicaid, take a look at those top two boxes. That's going to be your required information and your required forms and documents that you'll need to complete the entire application. it is extremely beneficial to have all of this information pulled together before you even begin the application process. When we did our work groups with the CAP Center, we were able to get through the online portion within about an hour with a small group of pharmacists. Where we would take pauses and make sure everybody's on the same page. So that being said, if you have looked through your required forms and documents ahead of time, you can generally fill that out in tandem with the online application because a lot of the information is repeated because those are supporting documents for what you're putting in the online application. And then the point I typically belabor here is that you absolutely need to write down your application tracking number as you're starting the online application. If you don't have a full hour to dedicate to it, or you get called away or anticipating not being able to finish it, that number can be used to recall your application and go back in and pick up where you left off before. So absolutely, probably one of the most crucial pieces of information that you can hang on to when you're applying. The other thing I'm going to point out here is that once you hit submit on your online application, you have about 5 business days to get your supporting documents turned in. So just keep that in mind. If you're not going to be ready to send in your supporting documents, then you might want to hold off on actually clicking that submit button on the online portion of the application. So again, this is only the North Dakota Medicaid enrollment process, and it's a super high level overview of it. There are a lot of great resources on our webpage under provider enrollment. They have small digestible videos where you can go and watch someone complete the form. It's not pharmacist specific. I'm hoping to have something pharmacist specific published to our website within the next few months here. But they walk you through the steps of each page of the online application, and they're like under 5-minute videos each. So super easy to help walk you through the online application. And then again, if it's an expansion member that you want to serve, you would also need to enroll with Blue Cross Blue Shield of North Dakota. So how do you know if once you're enrolled, you're working with a traditional or expansion member? Lisa, you can go to the next slide. We would want to verify the member's eligibility. You can do that through any of the mechanisms I have noted on the left-hand side of the slide. So we have an online portal where you can check, or you could place a call to provider relations or through the automated system. I recommend checking a member's eligibility before providing each and every service. We're not in a scenario like we were during the pandemic time. Members may now go off of Medicaid or potentially move from traditional to expansion or vice versa. We have to do more eligibility checks. There are things happening at the federal level that's affecting how we have to do eligibility checks. So just something to keep in mind and make sure that you know who you need to be billing if you're going to provide a service. If the member's not on Medicaid anymore, do they have no insurance? Are they able to pay for themselves? And then if they are on Medicaid, are they on traditional versus expansion Medicaid? If and when you do want to check the eligibility, you do need to have 3 of the pieces of information on the right-hand side of the page. So just make sure you have that handy when you are going to check eligibility. And keep in mind, though, that this is an opportunity to, if you don't have time to do this step, perhaps you can delegate this out. Maybe a student pharmacist can help you, a technician can help you in this piece. And it's just keeping forward thought towards who you're going to be billing ultimately for the service that you provide. So when we go to the next slide here, I've got a couple of screenshots from the resource that I had linked on the previous slide if you use the portal to verify. Now, I'm going to call your attention to the benefit plan and plan description sections. That's where you can identify the type of Medicaid that the member is on. If it's traditional Medicaid, you're going to see Medicaid fee for service under the plan description. And then for expansion, you'll see ACA Medicaid expansion. Now, this is important because remember we said these are going to be medical claims if you're billing for services. So they've also added a nice little red text banner, and I'm sure it's small, but under that eligibility confirmation, it tells you that you're going to submit medical claims through the MCO. if they're on expansion, and then prescription claims through North Dakota Medicaid. So they've tried to make this a little bit more straightforward in being able to identify where your claims are going to go. So let's say that you've enrolled as a provider, your member is eligible. What types of covered services does Medicaid currently allow pharmacists to bill? Next slide. Thank you. There are a lot of great resources on the Medicaid website. I don't have time to go into each of them, but I will highlight a couple of things here about the tools and links I have on the right side. We used to have a separate Medicaid medical billing manual for pharmacists and pharmacies to use, but that's been migrated into the pharmacy provider manual. So that second link on the right-hand side does have a good overview of medical billing and includes codes for some of the more commonly provided and covered services on the left-hand side of the screen. But ultimately, the best information for medical claims is going to be found in the North Dakota Medicaid provider information pages, which is that top link. From there, you can also get into the provider guidelines, manuals, and policies, as well as the fee schedules and procedure code lookup tool. And I want to emphasize how good those resources are. If we are going to be billing as providers on claims, we have to get familiar with these documents that are applicable to all providers. The guidelines, manuals, and policies are going to include information about timely filing. And I mention that here because it's different for medical claims than it is for a traditional drug claim through the pharmacy. It goes over what meets the definition of being medically necessary. It talks about documentation, which I will go over a little bit here, and so much more information. And then the procedure code lookup tool gives you the opportunity. You can just punch in a CPT code or a HCPCS code, and it gives you the current reimbursement rate if the code is covered, indicates whether prior authorization is required, identifies if ordering, referring, and prescribing NPIs are required on the claim. A lot of information can be pulled from that lookup tool. So it's kind of fun to go in and play with it. Can certainly look up MTM codes there and see what's required for being able to bill MTM. So again, I've just listed a few of the most commonly billed pharmacy services here. But again, I want to point out that just because a code is covered doesn't mean there aren't limitations to certain codes. Also, if you are in a practice setting that is a little bit more unique, like IHS or an FQHC, there might be other limitations to how you can bill, or you might have to use a different type of claim. I'm mostly going to talk about an 837P transaction today, which may not be applicable for IHS. So if you do have more specific or niche practice things, I can certainly be a resource for that. You can email me outside of this, but I'll focus mostly on what's going to apply a little bit more broadly. I do want to take a little bit of time to discuss MTM a little bit further, so we can go to the next slide, Lisa. With MTM, I'm calling this out intentionally because I wanted to point out we've been pretty liberal in our MTM guidance to allow pharmacists to bill a variety of services under these codes because they're intended for and structured for pharmacists to use. Obviously, our practices are growing, expanding, and we wanted to make sure that a lot of different types of services could be encompassed under these types of codes. So of course, in that medication use box, we have some of the more traditional types of MTM where you're looking at deprescribing, adherence, maybe transitions of care. But we've also added in things like health literacy, where if you're spending a lot of time outside of your usual workflow in coordinating care or working with a member to be able to better navigate their health care, that could be an opportunity to be reimbursed for services that you're providing. Harm reduction is something else that we have added in and called out specifically because we've tried to highlight pharmacists as an avenue for meeting our harm reduction criteria for hepatitis C PA. But it's not limited to just that PA criteria. If you work with members who have alcohol abuse in their history, and you're talking to them about harm reduction or persons who inject drugs, all of those things could potentially be reimbursable under MTM, especially if you're making referrals to other services and doing some additional counseling on how to have harm reduction. And then one of the broadest areas is the disease state management category. If you're working on guideline-based therapy for members and you're finding problems in their drug therapy, you certainly can leverage MTM as a way of billing for your services. And then on top of that, some of these services may be done in concert with prescribing. So if we go to the next slide, you can see here that I have highlighted a few headlines and legislative chapters that have been some changes in our state over the past few years. These give pharmacists more independent authority in caring for our patients, but prescribing can happen through a few different pathways. We can have collaborative practice agreements, protocols, and then, of course, some of this independent prescribing authority. But there's also been a couple of key changes in naloxone and norgestrel through Opill becoming available over the counter. As we get more authorities and as some of these products become OTC, there are a couple of other state and federal pieces of legislation that come into play for Medicaid. So if we go to the next slide, Lisa. I'm pointing this one out because non-prescription drugs still have to be prescribed for North Dakota Medicaid to be able to pay for those drugs. We could certainly be a prescriber for an over-the-counter medication, but for North Dakota Medicaid to be able to pay for that prescribed drug, the provider still has to be enrolled. Naloxone is one where there is a standing order that Medicaid has put out. So if you're not an enrolled provider, you certainly could have the standing order prescriber be on that particular claim. But if you are enrolled and you are prescribing naloxone, you certainly could be the prescriber on record through North Dakota Medicaid. But keeping in mind also that you have to be using a product that participates in the rebate program. So that was the quick and dirty general overview of basically getting to the point of being able to provide services for our members. So let's say you have enrolled, you verified your member eligibility, you've provided a covered service, you've done all of those steps. What's next? Basically, we have to document it. If you didn't document what you did, it didn't happen. Documentation is something that we do kind of get a lot of questions about this, like what's expected for it. I'm going to typically defer to our North Dakota Medicaid Billing and Policy Manual. Again, we have some information in our pharmacy provider manual, but at the end of the day, we want this to basically fall in line with what you would typically see in a medical record chart note. There shouldn't be anything that's super surprising here in terms of the types of information that we would expect to be documented for clinical services that are being provided by a pharmacist. We don't require that you document in a specific platform, but whatever you do, you should be capable of tracking and reporting interventions and outcomes. It should be maintained in accordance with HIPAA requirements. But ultimately, we're pretty flexible to allow providers to use what works best for them as long as it's a quality system. And then once you've documented all of the pieces of your service, then it'll be time to bill for the work that you've done. So go ahead and go to the next slide, Lisa. So when we submit a medical claim for services, this is going to be, as I mentioned earlier, an 837P transaction, which would be the electronic format essentially of a CMS 1500 form. So if you're like me and you've seen those red and, well, the white form with the red boxes all over it, that's the one I'm talking about. That is what pharmacy services typically get billed under. Since it's a medical claim, you do have to make sure that you're submitting it to an appropriate payer for Medicaid members. So I mean either North Dakota Medicaid if it's a traditional member or Blue Cross Blue Shield if it's an expansion member. And if the service was provided to an expansion member, again, Blue Cross or MCO is going to take that claim. And then I'm just going to reiterate, timely filing is different for medical claims. So you only have a 6-month time frame instead of a whole year to get those claims submitted, which is still pretty generous in terms of the amount of time to bill a claim. And then for MTM services, if someone has Medicare, they wouldn't be eligible for MTM through Medicaid because that's a Part D covered service. Medicaid does not pay secondary to Medicare Part D. I mentioned earlier that you need to make sure that the codes are covered, but also follow any stipulations related to the code or your particular practice setting, if you are in one of those more unique types of settings. Outside of that, we have a few things that do come up pretty regularly in terms of questions or sometimes issues on claims that I wanted to highlight here for you. ORP providers, that stands for ordering, rendering, and prescribing providers. Some codes do require NPIs for those various types of providers. You can find that information out by using the procedure code tool. But if you have a missing NPI on a claim or an invalid NPI on a claim, that's going to cause the claim to deny. You will get codes back that tell you what the issue is. And this is where I am not an expert in finding the fields online. However, our provider relations call center is actually pretty good at helping people navigate and find the particular fields that they need to fill in if those items are missing. Again, certain codes are limited to certain providers, and then some codes are time-based. So when I'm talking about billing parameters here, just make sure that you're appropriately billing a code. If it's, say, a 15-minute time code, you have to spend at least half that time providing the service in order to be able to bill that time increment code. So just make sure as you go to provide services that you understand what exactly your codes that you want to bill for require. Another thing that comes up quite a bit too is taxonomy and specialty codes that are billed on the claim have to match that which was used when the provider enrolled. If for some reason you're using a different taxonomy or specialty code, then that claim will deny it when you go to bill it if that doesn't match your enrollment. So you'll either have to update your enrollment if you forgot to put something in that you wanted to, or correct your claim if you put in the wrong taxonomy or wrong specialty code. And if you think you've done all of those things correctly and it's still not going through, I don't want you to think that we sometimes don't have issues, because we do. We recently had to put in a programming request to add a specialty code for 795 as prescribers. That is a pharmacist code. If you are going to leave this session today and be really motivated and enrolled, don't use that code yet, because we're still working on getting that added into the system. But there are other pharmacist codes that are appropriate to use for a specialty code. So you certainly can use that one, just not the 795 one right now. But in line with that, that was someone reaching out, letting us know, hey, I'm billing these claims. They aren't going through. I think I've done all the things I need to do. And that's how we identified that this was something that we had to get updated within our system. So please know we're accessible. And again, we're open to feedback for things. And then, of course, if you are providing a service that requires prior authorization, you do have to include your service auth number on the claim. Otherwise, that will also deny. So those are some of the common things that I encounter. And of course, you guys are going to have some time to talk amongst yourselves. And I'm sure there will be other things that come up that I haven't noted here or don't know about, but please share pearls with your cohorts so that they don't run into issues that you maybe had to work through along the way. Okay, so that soup to nuts is basically billing for services. And how you need to work through that process. So what opportunities do you have to identify, or how can you identify people who might be appropriate for some of these services? Well, Medicaid doesn't send out a list of members who are eligible for various services. However, we do have a couple mechanisms that we use to notify both prescribers and pharmacies of potential drug therapy problems. We have lettering that occurs almost monthly. That's generally retrospective, a second bullet that I have there. Those go to the pharmacy as well as the prescriber of drugs for whatever it is that we're screening for that month. Since they're retrospective, the members already have the drugs in their possession. They could potentially be having issues. They may not be having issues. They're just alerts, but could be opportunities for you to have interventions and potentially bill for services. We also have hard and soft edits on pharmacy claims. So those are the point of sale messages on pharmacy claims. If it's a hard edit, that means that the claim's rejected and it requires some action to be taken at the pharmacy to correct whatever the issue is on the claim. So that might mean something as simple as I have to call and have an override entered for a loading dose on a new drug. You might have to contact a prescriber to discuss dosing frequency. In some scenarios, the member might not be taking their medication as prescribed. GLP-1, for example, some of the doses are not indicated for glycemic control. So we would have a hard edit on that saying you can't bill for Victoza or liraglutide 0.6 milligrams per day ongoing, just for loading for initial titration. Other drugs, we might have a soft edit, meaning the claim will pay, but maybe the member is not filling it as frequently as they should be. They got a 30-day supply of lisinopril 20 milligrams, and it's been 90 days since they last filled it. So you might get a message on their next fill saying they've only been in possession of this 33% of the elapsed time since the last fill. Those are opportunities for you to potentially have interventions, work with members, and bill for services. So ultimately, while we might highlight some opportunities through those processes, it's ultimately going to be up to us to enroll, engage in providing the services, and then bill for those services. And I'm going to share a little data here to underscore the importance of that last bullet and hopefully give you some food for thought as you go into your roundtable discussions. We can go to the next slide. So we have had a big increase in the number of pharmacists enrolled. I don't have an opinion as to whether this number is good, bad, or otherwise, but we do have certainly more licensed pharmacists in the states than this enrolled. But as you can see, we had a big spike in 2023. That was a corporate retail push to get some pharmacists enrolled across a chain. But after that, you can see that we're having, 25, 35 people enroll over the last few years here. More pharmacists are graduating in that, so are there opportunities to get new graduates more engaged, wanting to enroll right when they get out of school? What opportunities do we have here? Even more interesting than this, though, I think as we go to the next slide, I found this to be particularly interesting. So in 2024, we had about 260 pharmacists enrolled, and of those, only 72 were billing for our most commonly billed services. So a little over a quarter of the pharmacists who were enrolled in 2024 billed for these services. That includes all claims, both paid and denied. And the majority were billing about one service a month to one service per week. And then if you look to 2025, which we can go to the next slide, this is data through September. So the number of claims billed has gone down a lot, and the number of pharmacists enrolled that are billing is just under 20% now. So how can we shift more of this orange into the green? And how do we get more pharmacists billing for services? Are they doing services and not billing? Are they just not doing services? Are members not open to having services from pharmacists? What's happening? I don't know. I hope there's good discussion here, but there's certainly opportunity, and you can kind of see what has been happening. But it's not all sad. I think that you can see the people who are providing services, some of them are quite active too. Lisa, I want to go to the next slide because I also want to, while we are maybe not having as many pharmacists billing for services, we do have pharmacists involved in a lot of different areas of patient care. So in 2024, I'm going to focus on that big one in the middle. We had 34 prescribers with a pharmacist specialty and a paid claim. So 34 prescribers that were pharmacists had paid claims, about 460 paid claims. But I really thought it was interesting how many different types of things pharmacists were prescribing and the different types of care that they were providing. So, what ideas do you get from this? Smoking cessation is really the big one where I've been prescribing. So, maybe that independent authority in that area has affected that. But again, just very interesting to see all the different types of things that people are doing. Um, and then that's all I have for information to share with you today. We have the round tables to go to, so hopefully you guys have, um, like you said, some good food for thought to share with each other as you go.